MD from the University. Dr. Fenves received his MD from the University of Texas Southwestern in Dallas. He then spent 2 years at Washington University in St. Louis in internal medicine prior to returning to Dallas to finish his residency and complete his nephrology fellowship at Baylor. He then spent the majority of his career in private practice nephrology in Texas while remaining heavily involved in the internal medicine residency and nephrology fellowship training at Baylor. During this time, he performed groundbreaking clinical research, including the identification of beta-2 microglobulin as the cause of dialysis-related amyloidosis, as well as the identification of 5-oxyproline as a novel cause of anionic metabolic acidosis related to acetaminophen use. He also won numerous teaching awards at Baylor, which led him to be recruited to Massachusetts General Hospital in 2013, where I came to meet him. As an inpatient clinician educator, where he's heavily involved in teaching and mentoring for both the internal medicine residency program as well as the nephrology fellowship program. And on a personal note, I was extremely fortunate to have Dr. Fenves as a mentor during my training in Boston, and he is a big reason why I ultimately chose to pursue a career in nephrology. So with that, I'd like to welcome Dr. Fenves, who will be speaking to us today about non-cirrhotic hyperammonemia.
Wonderful. Can you hear me okay?
Yes.
Okay, great. Greg, thank you so much for that very kind introduction. And I have just the greatest and loveliest memories working and rounding with Greg. It was just such a pleasure and getting to know him personally. So welcome. And I know I'm sorry for the timing. It's Yom Kippur today, but I know that this is being recorded. So those of you who will watch this later, I hope I can be of some help. And so I'd like to, as Greg mentioned, talk a little bit about hyperammonemia and renal replacement therapy. So here are my disclosures, and one of them is relevant. I do write, one of the chapters in Up to Date is about RRT and hyperammonemia, and I receive royalties. So let me give you a little overview of what I would like to talk about over the next 40 minutes or so. I like to start with a kind of a personal historical perspective of how I got into this area in the first place. And then we'll talk quite a bit about GABA syndrome. And then I'll widen the scope and talk about hyperammonemia and renal replacement therapy in general. And then we'll talk a little bit about limitations. So you may well ask, how does a nephrologist like me, mostly, as Greg mentioned, mostly in private practice, although always with a clinical interest in Dallas, get into this area? Well, this all started, as not unusual in clinical medicine, with a single case. This was about 16 or 17 years ago, and I was consulted. I was still in Dallas at Baylor University Medical Center. We were consulted on a 46-year-old lady who was found unresponsive. She had some history of seizures, bipolar disorder, some lung disease, a previous pulmonary embolus. But very relevantly, she had a previous, specifically Roux-en-Y gastric bypass surgery for obesity, which apparently was very successful. This lady lost well over 100 pounds. And very significantly, she had no liver disease. Now, we were consulted for the following reason. On admission, as I mentioned, she was unresponsive. She was intubated for airway protection. But somebody has spread out a wide net in terms of differential diagnosis regarding her altered mental status and got an ammonia level, which was very, very elevated at 450. I might mention that the normal level does vary from hospital to hospital, but it's usually below 45 or so. So this was a very significant tenfold elevation. Other interesting aspects of this lady's laboratory included a very low albumin of 1.8 grams per deciliter. Her glucose was normal. They did do a lumbar puncture because of her ultramana status, which was normal. She was anemic. She had normal appearing renal function. Her AST and ALT were mildly elevated. And again, after she was admitted to the ICU because of the high ammonia, they started investigating her liver, but she had no evidence of cirrhosis. So the question that was posed to me with the consult was, this is a very high ammonia level. would you dialyze this patient? Now, again, this is 16, 17 years ago. And my answer at that time was, of course, I'm not going to dialyze. My training prior to this said, why would you ever dialyze for hyperammonemia? Plus, to be fair, I didn't know anything really deeply about that in any case. So the treatment included a low protein nutritional support. I recommended, of course, lactulose. Because the ammonia was very high, we did use IV sodium benzoate. And indeed, I was kind of celebrating myself because the ammonia fell in 2 days to 90. We started thinking about this lady deeper, however. I said, it's all interesting that she had so hyperammonemia, but why did she have that in the absence of liver disease? So that's why we began to look at some other issues. So we did check blood zinc level. I will return to that later. Her mental status remained poor, and she remained ventilator dependent, and eventually developed sepsis. As I mentioned, no RRT was recommended. So the question was, why not? Well, the year was 2006, and a lot of things were still unknown about hyperammonemia. We did know about urea cycle defects, especially in neonates and young children, and there was no question that renal replacement therapy was employed in that setting. But when we thought about hyperammonemia, we kept thinking about people with liver disease rather than urea cycle defects, because urea cycle defects tended to occur early in life. And so in adults, this was less of an issue. So I simply said no. Now let me give you the follow-up. So the pushback, of course, was, why not dialyze for hyperammonemia? So let me very quickly review, and we'll return to this later, but let me quickly review the dialytic properties of ammonia. Well, the diffusive clearance of ammonia is very similar to urea. So it should, and indeed does, dialyze off very well. In vitro clearance has been estimated as high as 225 mLs per minute. Again, similar to using those large dialyzers for urea clearance. It is not protein bound. The clearance depends on blood flow rate, dialysis flow rate, and the membrane surface area, as I mentioned. And it has been known, even many, many years ago, that hemodialysis achieves the highest clearance. By the way, CVVH and CVVHT were just then beginning to get more popular, and they're also very effective on maintaining lower levels of ammonia. So at least theoretically, why not dialyze for hyperammonemia? Now let me continue with this case. She spent 10 days in the hospital. Unfortunately, her encephalopathy never improved. And what was fascinating, even though we managed to lower her ammonia level down to 90, within a couple of days, it rose again, despite the sodium benzoate and the lactulose and maximal therapy. And actually, her ammonia went to as high as 530. And ultimately, neurologically, she remained devastated. She died. Again, the key features, this was a middle-aged woman without cirrhosis, prior Roux-en-Y gastric bypass surgery. She had hyperammonemia with significant encephalopathy, a very low serum albumin, a low serum zinc level, and death. So this got me interested. And incidentally, my very first thought was that maybe she had, she was an adult, but maybe she had a urea cycle defect, and the immediate enzyme that became a suspect was ornithine transcarbamylase, or OTC. So, but let me jump ahead and say that over the next few years after that, we found 4 other women, so a total of 5 women, ages 26 to 58. All of them had Roux-en-Y gastric bypass surgery, some very recently, like 3 months, others many decades prior. None of them had cirrhosis. We had liver biopsies or autopsy biopsy of the liver in all of these patients. They did not have cirrhosis. They had very low albumin. You see the range there. Their ALT and AST were mildly elevated. and ammonia ranged to very high levels, and all died. Now, my initial theory, as I mentioned, was that they had an OTC mutation. And by the way, this can occur in adults. And the reason is the gene coding for OTC is on the X chromosome. So women with two X's can have a normal and an abnormal gene and live into adulthood with about half the enzymatic activity without any problems. So my initial theory was easy. Oh, well, this is easy. They have a bad X and a good X. But it turned out that genetic analysis for OTC mutations were negative using Sanger sequencing. And this is the article we published in the American Journal of Medicine in 2008. Now, let me jump ahead. A few years ago, about 6 years ago now, we published a larger series in the journal Obesity. By the way, what is a nephrologist doing publishing in a journal like Obesity? But in any case, we described this new hyperammonemic syndrome, which we called GABA syndrome. We by then collected 20 cases from the literature, including 11 from Baylor University Medical Center over a period of 10 years. Our inclusion criteria was we were looking for a successful Roux-en-Y gastric bypass surgery, successful in the sense of weight loss, the development of hyperammonemic encephalopathy, not just hyperammonemia, but actual neurologic symptoms. We were looking for the absence of cirrhosis, so those patients who had severe liver disease and cirrhosis were excluded. And these patients were identified by literature search. And by that time, I started getting invitations, not invitations, but phone calls from around the country with cases from elsewhere. So of these 20 patients, 19 were women. Mean age was 45. They had encephalopathy anywhere from a few weeks to many, many decades. And amazingly, unfortunately, the mortality rate was 50%. There is the ammonia range, and then symptoms ranged anywhere from mild confusion to coma. Initially, we had an interesting theory. 10 of these 15 patients had episodes of hypoglycemia during their hospital course. So we thought about nesidioblastosis. Now, initially, I thought nesidioblastosis was a fungal infection because it sounded like it, but it isn't. Nesidioblastosis is actually pancreatic hypertrophy. And the idea is that these patients are overweight, have pancreatic hypertrophy, and after the Roux-en-Y gastric bypass, this pancreatic hypertrophy does not recede for a while. And so you actually have hypersecretion of insulin, at least for a little while, and that leads to episodes of hypoglycemia. But I don't think this theory has really fared well. We looked at baseline insulin levels, and they were normal in 2 patients and were only elevated in 1 patient. We didn't understand why these patients are severely hyperalbuminemic. I still don't know. Perhaps it is a malabsorptive state. That's possible, and their protein malnutrition. ALTs were mildly elevated, and bilirubin levels were normal in where it was measured. Zinc level was very low. So let me mention about zinc. The reason we got interested in zinc is a cofactor in many of the urea cycle enzymes, but in particular with OTC. So a low zinc level might contribute to lower in vitro, I should say in vivo, ornithine transcarbamylase activity. We had liver biopsies in 13 of these 20 patients. And to be fair, they weren't normal, and you wouldn't expect it to be normal because these patients all had obesity and therefore probably at least some hepatotoxicity, maybe from fat deposition. And indeed, many of the patients had fatty liver. Some had mild fibrosis up to stage 2, but none of them had actual cirrhosis. Really, the kind of cirrhosis that would explain the onset of hyperammonemia on that basis. And interestingly, glutamine levels were high and citrulline levels were low in some patients. And this again illustrates that high glutamine and low citrulline levels in terms of enzymatic activity tends to favor an abnormality or an abnormal function of OTC. Notice that in this slide, it's actually called, it's the second enzyme, it's called ornithine carbonyltransferase. It's an equivalent word for ornithine transcarbamylase. It's just a matter of nomenclature. So everything pointed to OTC, but the genetics was normal. Now, because of that, we were lucky, and in 3 cases, we actually had a fresh frozen liver tissue. This was obviously pre-mortem. And the ornithine transcarbamylase activity was very low in 2 patients, was normal in 1. By the way, not many centers around the world can measure in vivo activity of the OTC enzyme. These 2 of these 3 activities were measured at Baylor College of Medicine, not in Dallas, but in Houston, with the help of a wonderful Howard Hughes investigator who happens to have the tools and research availability to measure OTC activity in vivo and actually give us an enzymatic activity. Again, it's also interesting that, of course, we're all dealing with women here. Males who inherit a mutated OTC gene usually have severe, often lethal elevations of ammonia in the pre and perinatal course and don't live into adulthood. There are like 1 or 2 exceptions, but that's extraordinarily rare for a male to be able to live into adulthood. Again, I already mentioned that the OTC sequencing in the patients did not show any abnormality, but I will say that the OTC gene is very large. I think it's got 13 codons, and it's 20% of the mutations may not be detected. That's kind of the latest. Now, Greg asked me about anything really new. We started kind of a data search between the Mass General Hospital and Brigham and Women's Hospital partners, the 2 sister hospitals, if you will. And looking back at data over 15 years, we identified almost 9,800 patients who underwent Roux-en-Y gastric bypass surgery. Now, very interestingly, about 1%, so almost 1,000 patients had almost 100 patients, 1%. So this was almost 10,000 patients. So we're looking at like 100 patients had hyperammonemia, low serum albumin, and were non-cirrhotic. 3/4 of them were women. Now, I'll be honest with you, we did not go materially into these charts. It was very difficult, very time consuming. Some had liver biopsies, some didn't, but none of them had cirrhosis. And there was quite a few who died, about 25%. The reason I did this preliminary evaluation is to just get a very rough idea of how rare or how common is this. And of course, I think it's relatively rare, but it's not quite super rare. And so my best estimate is somewhere between 0.5% and 1%. And I think for some reason it's all in women. So what is the hypothetical pathophysiology? These patients may have a partial X-linked OTC deficiency. Maybe somehow they belong to the class of 20% where we don't recognize the known mutations. Maybe there is an acquired ornithine transcarbamylase inhibitor. And maybe there is a perfect storm of non-genetic factors such as zinc deficiency, post-surgical catabolic protein breakdown, protein malnutrition, maybe even gut microbiome that has changed after the Roux-en-Y, which favors urea splitting organisms and perhaps increased ammoniogenesis. And maybe it's a combination of all of these, but these are just theories. All right, so I just want to summarize, and then we'll move on to the rest of the hyperammonemia issues. We proposed that there is this new clinical syndrome in patients after successful Roux-en-Y gastric bypass surgery, perhaps in as much as 0.5% of women with hyperammonemia in the absence of cirrhosis, severe hypoalbuminemia, low zinc levels, a high mortality rate in a female predominance. Okay, now let's look more at the wider subject of renal replacement therapy and hyperammonemia. I'm going to use HA as hyperammonemia. So I don't know about your institution, but on the renal service, we're getting increasingly larger number of consults about hyperammonemia, where dialysis should be considered or is to be considered, or the question is, should we do a dialysis? So let's look at some scenarios. Liver disease. So I think this goes back to my classic training back some, I hate to admit it, 40 years ago or so, where we saw a lot of liver disease, of course. Cirrhosis was present. It was obviously of gradual onset, and hyperammonemia tended to be a fairly late onset. Now, in this setting, I think we would all agree that when we're called on a patient with cirrhosis, well-known liver disease, perhaps end-stage liver disease, with a gradual onset of hyperammonemia, that renal replacement therapy really has no role. Now, I say that is because when hyperammonemia develops slowly, in other words, when the tempo is very slow, a lot of changes take place in the brain that are chronic and irreversible. And renal replacement therapy might actually physically or chemically lower the ammonia level, but it's not going to be clinically of any value or any use. One way to think about it, which I might mention now, is when hyperammonemia develops gradually, ammonia can and does cross the blood-brain barrier, enters the brain, where astrocytes, which are, if you will, the and ultimately try to degrade this foreign substance. But with the increased levels of glutamine and other substances, the astrocytes will start swelling. And a lot of folks feel that chronic hyperammonemia and eventual cerebral edema occurs because of the astrocyte swelling. And once that happens, irreversible changes and neurologic damage occurs in the CNS. And therefore, renal replacement therapy and lowering ammonia levels really don't have a role. Now, what about acute liver failure? I'll mention a few words more about that. I think in acute liver failure, where they often do present with hyperammonemia, I think renal replacement therapy may have a place. Now, it's in some sense fortunate for us nephrologists that many patients with severe acute liver failure also have acute kidney injury. And I say that especially in ischemic hepatopathy. I think we all know that the liver tends to be protected from a circulation standpoint because of its portal circulation as well as arterial circulation. So when there is ischemic hepatopathy, there's almost always ischemic ATN as well, at least in my experience. And then the decision whether to use renal replacement therapy or not is easier because there's also AKI. So I think there is a role there for renal replacement therapy. How about hyperammonemia and AKI? Again, a similar story. One may then decide perhaps use looser or more liberal criteria for the AKI in terms of initiating renal replacement therapy, knowing that there's also hyperammonemia. Should also point out that when there's decreased kidney function, there's decreased ammonia elimination, and so hyperammonemia will be more severe when there's also a decreased GFR. Now, what about chronic kidney disease, hyperammonemia, and altered mental status? Again, I think here medical therapy, lactulose, rifaximin, sodium benzoate, other ammonia traps, carnitine has been used. All of these things may be more valuable and actually work just as well or better than renal replacement therapy. And then we have, again, that last category of the absence of liver disease, hyperammonemia, and no AKI. And this is, of course, controversial. I will touch base on this a little later. So let me just mention a few words about acute liver failure. Of course, we're all know the causes, the potential etiologies of acute liver failure. Drug overdoses. I don't know about Canada, but it's very common, I know, in Great Britain and England. I think it's the #1 cause of drug overdose suicide attempts. viral infections, which I already mentioned, ischemic hepatopathy, autoimmune hepatitis, and Wilson's disease. So many of these patients these days end up on the very active liver transplant list, often on the top of the liver transplant list, even acetaminophen overdoses, paracetamol, I think, in Canada. And I think in that setting, renal replacement therapy may be indicated here as a bridge to orthotopic liver transplant, even in the absence of AKI. Although, as I mentioned, in ischemic hepatopathy, AKI is very commonly present. Now, recently, one of the renal fellows at MGH, Harish Shithipati, and myself, Harish just became a junior faculty, so I'm very proud of him as well. Following in the footsteps of the great Dr. Greg Hundemer. Harish and I wrote this article about, in particular, lung transplants and organ transplants. But in this article, we have a table of causes of non-hepatic hyperammonemia. And it turns out that organ transplantation, this occurs not infrequently. I will mention more about lungs in a minute. Lung is where it's quite significant, much less commonly in heart transplants and bone marrow transplants. There are a couple of cases of even kidney transplants where hyperammonemia developed. When it comes to drugs, valproic acid is the most common, but there is a whole variety of others as listed. We already talked about urea cycle defects, rarely in adults, usually OTC enzyme. Urease producing bacteria, urinary diversion, such as ureterosigmoidoscopy, although ureterosig is not used very much. It's a very morbid procedure with lots of complications, but some still, of course, do ileal conduits, and this can occur there. We already mentioned GABA syndrome and then hyperalimentation. I wanted to spend just an additional minute on hyperammonemia in lung transplant patients, because the incidence here could be, in some series, is as high as 4%. The cause is still idiopathic, although I will show you kind of a theoretical slide. Peak ammonia levels are often very high, sometimes in the thousands, and it actually has very high mortality. And early recognition here, I think, is very important. So if a lung transplant patient has mental status changes and encephalopathy, I think checking ammonia level is essential, because early intervention and renal replacement therapy is absolutely indicated here. Now, why lung transplants? And I'm sorry for this very, very difficult slide. And this is just a matter of illustration to show you that ammonia handling is quite complicated. It's not just, it is complex. And you could have, we already mentioned the urea cycle with partial deficiencies. It turns out that muscle at the bottom of the slide, ammonia uptake by skeletal muscle is very important. It's also converted to glutamine, like in the brain, which then enters the urea cycle. If you have sarcopenia, perhaps this reduces, if you will, ammonia trapping and might lead to hyperammonemia. We talked about urease producing bacteria, which can increase blood ammonia levels. There are issues with hypokalemia, alkalemia, and acute kidney injury as well. So this is really just a way of illustrating that ammonia handling is complicated, and this should come into our equation when we think about dialyzing it, because there could be a lot of production and other issues that make our renal replacement therapy not as effective. I do want to mention, even though we're adult nephrologists, this issue comes up actually not infrequently in pediatric nephrology. And recently at the MGH, we had a wonderful grand rounds by one of the pediatric nephrologists who talked all about inherited urea cycle defects. And these are now more than just OTC. There are many other urea enzymes that are much more likely to be seen in neonates. And here, these young neonates, or even in utero, they have brain swelling already because of critically elevated ammonia levels. And renal replacement therapy can and is used as a bridge to liver transplantation, if possible. Many of these cases, unfortunately, end up with kind of a tragic end because it's very hard to do RRT in these tiny humans, liver transplantation is a very difficult and complex and a difficult bridge to cross, so to speak. I will mention that in this setting, peritoneal dialysis can be used, and actually there are some articles on the use of peritoneal dialysis, but that you can use other forms, hemodialysis or continuous forms of renal replacement therapy as well. So, kind of in summary, when to use RRT in hyperammonemia. So I don't know if there are any definitive answers, but there's some clinical scenarios. Well, this may result in a successful outcome. I should mention that since our article in Obesity, by the way, in 2015, there have been several other publications, again, about GABA syndrome. Some of those patients had renal replacement therapy and survived and did well, even without, some with neurologic deficits, but others without, when they were started early. So this can be very successful and potentially life-saving, but the data is very scant. Again, just to remind you of the previous slide about the dialytic properties of ammonia. So certainly we can't push back on saying that it doesn't dialyze off. It does. Now, here's our approach. This is not necessarily anything unique, and I think other alternatives exist. This is what we ended up agreeing on in our up-to-date chapter. Because hemodialysis is so much more effective in lowering ammonia acutely, we start with hemodialysis, usually 4 to 6 hours at blood flow rates of 400 to 450 mLs per minute, dialysis flow rates of 800, pretty standard. Because there is a rebound effect potentially, and remember there's also maybe production issues, we immediately transition the patient to CVVH or CVVHD. So for example, we might employ this in a patient with acute liver failure where the GI hepatic transplant team already is strongly thinking about listing that person for, or have listed the person for a liver transplant. We would then approach that hyperammonemic patient this way. As you might imagine, these patients can be very, very ill. So you may have to reduce blood flow rates and dialysis flow rates if they're hemodynamically unstable, and they're not infrequently, they are hemodynamically unstable. The endpoint obviously is clinical status and mental status. Sometimes that's not easy to tell because some of these patients are even intubated. And so when to stop, I don't know. Perhaps when they get transplanted or when the clinical picture becomes clear one way or the other. Now, many limitations, of course, as opposed to, for example, urea. I keep mentioning that ammonia and urea have similar dialytic properties, but of course, urea is a whole different story. Ammonia production may be accelerating as there is increasing liver failure. There may be bacterial production of ammonia. I already showed you that complicated slides about muscle and alkalemia and hypokalemia. There could be many, many other factors that could lead to increased ammonia production. That can be that rebound effect we talked about. Now, what about using a modality like renal replacement therapy? What is the effect of that on intracranial pressure? And that's very controversial because some articles would say that we may be interfering or affecting intracranial pressure in a negative way and actually inducing herniation, central nervous system herniation, obviously something we want to avoid. This is a rather controversial topic. Some folks feel that RRT is not a major player. Others feel that this can negatively impact IC. There's, of course, hemodynamic instability, and we may be leading to more shock, may actually be causing more ischemic renal damage. And of course, is this a bridge to nowhere? That's an obvious and difficult question. And finally, the issue becomes as well, if we rapidly lower ammonia levels, is there such a thing as a disequilibrium syndrome? And I don't know the answer to that either. I suspect there isn't, but I don't know that for sure. So let me just summarize by saying that hemodialysis is the preferred method of renal replacement therapy when a rapid reduction is desired. CVVH or CVVHD is then used to maintain lower ammonia levels if indicated. Peritoneal dialysis, I think, is primarily used only in neonates or because of the low volume of distribution. And again, the best clearance is achieved via high blood flow rates, high dialysis flow rates, and large surface area dialyzers. There are certainly no standards for use of RRT in hyperammonemia. Maybe acute liver failure, as I mentioned, AKI in patients with chronic liver disease, or AKI in patients with acute liver disease. And then the potential uses we already covered, including those selected non-hepatic hyperammonemia states. And I would emphasize lung transplants and maybe GABA syndrome in those. So I just thank you for your attention. I wanted to acknowledge both the renal division and the core educator division at the MGH, and my co-author on the obesity paper, who is at the NIH, Oleg Shelokov, and then Stuart Speckler and I were the first to kind of get involved in this through the GI division, and then my old mentor Mike Emmett at BUMC. And thank you so much for your attention.
Thank you, Dr. Fenves, for that excellent talk. I'll open it up to see if anybody has any questions. One question, I'll start off with one question I had was, you talked about this post-Roux-en-Y gastric bypass. I was wondering if you have seen this with other weight loss surgeries as well, or other weight loss procedures, or is it unique to Roux-en-Y?
I think it's unique to Roux-en-Y. This is a great question. We haven't really looked at, for example, gastric stapling. I should also mention, Greg, by the way, that Roux-en-Y is getting to be a little less popular because it has a lot of other complications. When you look up Roux-en-Y, forget GABA syndrome, there is a whole list of other things. And so surgeons tend to go away from it. Having said that, there's still, like I showed you, almost 10,000 surgeries at the Brigham. But I think it's unique to this one, the GABA syndrome is. But we haven't looked at a large series of, and there's been no reports that I'm aware of in non-Roux-en-Y gastric bypass. What do you have a large database, Greg? Right, in Ontario, is it, or?
Yeah, we have, because it's kind of more government covered healthcare here, that they do have like provincial databases where they can, I'm sure they can capture Roux-en-Y gastric bypass and those sort of things, and they capture lab data. It's a little bit limited getting some of the granular details, but you can capture kind of a wide population with those databases.
You know, my suspicion is that in clinics, and I tried to do this at the MGH, but have not been very successful. I wonder if in those clinics, weight control or weight loss clinics, where they follow patients post-Roux-en-Y gastric bypass, I wonder how closely they monitor serum albumin levels. But if they do, and they begin to see the fall and the development of hypoalbuminemia, that would be an interesting time to, for example, check both zinc levels and ammonia levels. Because I think by the time they have neurologic complications, that is confusion, encephalopathy and such, these levels are much higher, and we may be late in the game. So even though I emphasize the 50% mortality, I think that's because of late recognition of this syndrome. This may occur early and maybe even reversible by simple means like zinc supplementation. Or, by the way, one thing I didn't mention is we've also started measuring selenium levels, and they're also low. Now, I have no idea why selenium levels are low, but that will be yet another area to look at. What about, let me ask something from the audience, since there seems to be such quiet. I don't know whether I didn't make any sense or it's just, but are you all getting consults for hyperammonemia? Because we certainly are, not so much in the cirrhotic patients, but we still get even in some of those, but I wonder if this is an issue or this is one of the consultative dilemmas or not in your hospital.
I think Ted's on the call. I'm not sure. Ted does a lot of the ICU medicine here. He might know kind of how many cases of this we see.
Thanks, Dr. Fenves, for that great, that excellent talk. I mean, my personal experience is that I've only been consulted once, but it was a patient with, Postruin Y. So definitely the syndrome you described. So very interesting. And we did dialyze them. They didn't do well, unfortunately, but, and I actually talked to Greg at the time, and he mentioned that you were the one who had discovered this entity, so it was great.
Thank you. So no organ. You haven't seen organ transplant. They haven't.
I personally haven't, but again, my experience would be like I wonder if anyone else in the group might have. We don't do lung transplants at our center, so they're done mainly elsewhere. So we tend not to see those patients as much. But do you think that like do you think down the road there may be some rule for genetic testing prior to these surgeries, given you have these different patient populations? And
yeah, Ted, that's a fantastic question, because I thought about that kind of right away. Wouldn't it be amazing if we could identify the women who are at risk for this particular? Absolutely. But it would be nice to know whether this is really an inherited genetic issue or is this an acquired OTC problem. I'm now leaning more that it's acquired, but then I don't know, which is why it would be really interesting to screen early post gastric bypass to see what occurs to these women, primarily women.
The other thing, I guess, and I'm sorry you might have mentioned this, but I had some connection troubles early on, but just in terms of like gut microbiota, do you think that like is that?
No, absolutely. So because I may, as I mentioned at one point, it may be a perfect storm with zinc deficiency, protein calorie malnutrition, and a change in myobe. So it would be also very interesting to study to see what is the difference of the bacterial flora, the microbiome, after a successful. And here's the key: we've never seen it in somebody where it wasn't successful. So we've never seen it in obese patients. I mean, they're still overweight, but they are, generally speaking, it's all been successful Roux-en-Y gastric bypass. They lost a lot of weight, and I wonder if that absolutely changes their microbiome to the point of maybe increased ammonia production coming from there. That would explain even on our early cases where we had the big rebound. We treated them with lactulose and sodium benzoate, and they did well for a while, and then they just go back right up.
For the 50% of people who survive, do they require ongoing treatment? Do they require like long-standing?
No, so we don't have enough experience. Again, since there was a 50% mortality, I don't follow too many. I did look up the chart of a few patients. There was a patient that is not included in our obesity, in those 20. I've been in contact with a gastroenterologist in New Jersey, of all places. And yes, that lady required special TPN for years. A special TPN. And this wonderful gastroenterologist would call me periodically and say, I'm doing this, I'm doing that. This was her entire career. She was actually very frustrated because this lady was incredibly complicated to literally keep alive. She was one of the Roux-en-Y. But others, I was told, had this bad episode. They were dialyzed, they were sent home, and they did fine, or so I was told. Oh, and I'm sorry, that one other interesting thing I didn't mention is one person had a reversal. So they actually took down the Roux-en-Y, and that person did great. I don't know how complicated that is, but they undone the anatomy. I think that must be hard, but I think that was fairly soon after the initial surgery. So that wasn't many years later.
Good. Are there any other questions? Okay, well, if not, thank you very much, Dr. Fenves. That was an excellent talk.
Thank you, Greg, and be in touch. Thank you all very much.
Absolutely.
Thank you very much.
Thanks. Bye.